We're really focused on reducing caries prevalence within the community setting. And that's really the area that we use that collaborative practice. They have a holistic approach too with helping the family in addition to the child. And I think that's the two things that both of those organizations are really doing, is trying to have that holistic family approach. Everybody is just saying, hey, this does not count as a comprehensive exam based off of what we're seeing visually. This is kind of where we're ranking you at this moment, but you always need to at least see your dentist on an annual basis for, follow-up to care.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast. This is episode number 176. My name is Andrew.
My name is Michelle. Welcome back.
Yeah. So I don't know if you wanted to tell the story of what happened.
I'll give a quick rendition. I got back from Costa Rica and CDA and was excited to be home for a whole 8 days, and then was rushed to the ER with cecal volvulus. Yeah, I think that's what it is. Twisted colon and intestine. So they had to remove a large portion of my colon, my appendix, and suction back my intestines together. Such fun stuff.
Yeah.
Today is 7 days since surgery.
No one rallies better than Michelle, but even her, she couldn't rally this last week to try and put some stuff together.
I tried. I was in the hospital for 4.5 days, I think, and finally came home Friday night. And you pointed out that not everybody is like me, but I really think that they should talk about mental health when you're leaving the hospital, because even though I am in my mind, I know I'm not capable of doing things and this is going to be a slow, long recovery. I still have that drive. I need to be doing something. And I'm going absolutely stir crazy. But yesterday kicked me on my butt a little bit, so I'm behaving.
We do have a lot to get through and an amazing interview. Just some shout outs from some people that we met at CDA. Amanda, it was great to meet you. Thank you so much for taking some time to spend with us. Becky, who was at your Trivia Dent event.
Yay. Thank you so much for everybody who attended that as well.
Yeah. So that was nice to meet you in the person, Becky. I know her and I have talked on social media before. And then of course our friend Frances, it was nice to see her again too.
I didn't get to see her this time.
Oh, I know she really wanted to see you.
Yeah. It's never enough time on that floor, man. And I have some emails that I just wanted to quickly run through. Hopefully these people know that will listen and hear this, because I haven't responded because I was a little incapacitated last week. But we have an email from a listener. Her name is Melissa, and she said, I just love listening to both of you and your guest speakers as an adjunct faculty member in Pasco, Washington. Am I saying that correctly?
That's right. Go Pasco.
I'm always trying to motivate my students to seek opportunities to further their education and step outside the box, which I love. I love this email so much. I just have to tell you how thrilled I was after reading their recent discussion board. I posed the question, list 3 things you plan to do once you start practicing dental hygiene to stay abreast of new technologies so that you don't become the dinosaur hygienist. And they all responded that one thing they would do was listen to A Tale of Two Hygienists. I could cry. Keep up the good work, Michelle and Andrew. The students are loving you along with us veteran hygienists. Man, I know there's more teachers like Melissa out there, but how lucky are those students? What a great question to pose to them. Thank you, Melissa. Thank you for spreading the podcast to your students and for being an exceptional faculty member. I have no doubt. And then one from our fellow or listener for a while now, Chrissy. And she said, I want to thank you and Andrew. I've been a dental hygienist for 21 years and I have attended several CE courses. And there are some that get me fired up, but nothing like listening to the podcast. Thanks again for your inspiration. I will definitely seek you out in Texas. And that's for RDH Under One Roof. So you guys be sure to come find us at RDH Under One Roof in Dallas. And then one last one, because I just don't think that this topic gets as much love because it's not as sexy.
It is definitely a topic that you try and make us do a lot. And I kind of push back a little bit sometimes.
I can't laugh. It hurts too.
Straight face, everyone. Professionalism.
It's the one that I love and I really wish people would get on board more with, but it was the HIPAA and social media. I can't even say it without. Okay. I got to breathe. I can't laugh. So Rona, I hope I'm saying that right. Rona, Rona, said, thanks for inviting Noel Kelsch. Absolutely love dental law. And I've commented on some Facebook posts I've previously seen that scare me. Girl, you and me both. It has been really concerning to me, some of the things I've seen. I can recall a case where someone posted what seemed like a lot of info about a patient. And I asked if all the patient's rights were covered. And quite honestly, I can't even imagine how that thread went because they probably got snarky and defensive, as they always do on those posts. But I think good for you, Rona. Keep being an advocate for these patients because sometimes we do stupid things. And after just being in the hospital and just like bearing it all for every nurse every 12 hours, pretty much, I appreciate HIPAA to its fullest abilities for my privacy because you know, they could have just snapped a picture of me in my eye mask with my mouth gaped open, you know, like silly things that we just don't think about. And we're doing that to our patients. And we need to remember that we can't just say, the patient told me I could. That don't hold up in court, y'all. So thanks for reaching out, everyone.
Yeah, that was really good. So we got the little shivers, the little goosebumps. That was nice.
Yeah. Look at there. I can get on my soapbox even post-surgery.
Wow. No, I don't think anyone doubted that you could do that. So we have part 4, the end of our Cariology series coming at you here in just a couple minutes. It was kind of nice to see Brant and Edie over at CDA. Those are Brant and Edie of Mouthwatch fame. They have been sponsoring this podcast series on Cariology since the beginning of the month. And it was nice to see how busy their booth was. I think everyone's really getting on board with this.
It was busy. And I was actually able to use this Mouthwatch camera on my mission trip when I was in Costa Rica. And I wasn't doing teledentistry, which is the other part of Mouthwatch and teledent, but I was able to do a lot of patient education. And it's really great to sit them up and show them what I was seeing. And so this camera is really great. It has really great images and it's really not expensive.
Right.
And one thing that Edie brought up to me, which I was like, oh, duh. I was like, I have such a hard time. Like, feel like I'm relearning how to look in someone's mouth with that camera. And she was saying it's because we are so used to indirect vision with our mirrors. So we've taught that brain hand connection, right? Like to move in the way that it needs to move. And when you're looking at a camera, that's still direct vision. And that is where at least my little brain got wonky and I had to kind of I was like, how do I do this again? So, but it's a great camera and it has a year warranty and lifetime support. Satisfaction guaranteed over there at Mouthwatch. And they're cool people, genuine people. I like to support those people. And they just happen to have an awesome camera and technology to help us do teledentistry.
It's nice when all those things come together. Makes it easy to talk about.
It really is.
So they have a coupon code. It's ATOTH, ATOTH, and that's going to give you 10% off of every order. And that's in addition to the 10% that you get off when you buy more than one camera. So if you are a business owner out there, a manager, or even a hygienist advocating for your whole hygiene team, Purchase more than one camera. They're less than $300 each, and you get 10% off and then an extra 10% when you buy more than one. You also get some free swag, it sounds like. So check them out on episode 106 if you want to hear more about what they're doing over there. Check them out on their website, www.mouthwatch.com. And don't forget the coupon code ATOTH.
And so this week we are interviewing Sharity Ludwig. And Sharity is in the Oregon area, kind of with you, Andrew. Mm-hmm. And we do want to give one quick correction to something that we were discussing. You'll hear it in the podcast. But she wasn't sure if the Fuji triage sealant material was light cured or not. And it is not light cured, just for your information, guys. But Sharity is just an amazing human. She's doing great things. Hygienist in public health. Oh, my heart, it beats for you guys. So enjoy this episode with Sharity Ludwig.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
Okay, listeners, welcome to part 4 of our Cariology series. And we're really excited because you've been listening to our wonderful dentist. And now we are bringing one of you on, another fellow RDH. So welcome to the podcast, Sharity and Ludwig. Am I saying that correctly?
Yes, you did.
I screw up names constantly. So yay for me on this one. Welcome to the podcast.
I'm glad to be here.
So Sharity, I think what we'd like to start off with, let's just talk a little bit about your background, because we've had so far a lot of didactic, like the knowledge portion of it. And I think that you're going to bring a lot with your background to now clinical application of all the things that we've been learning about.
Alrighty. So my background is actually relatively interesting because my first job out of hygiene school was within public health. So I didn't jump right into practicing in a dental practice setting. I worked in Klamath County as a hygienist in the WIC office, just trying to coordinate pregnant women and young children to seek dental care for early childhood caries prevention. And then about 9 years ago, I began working for Advantage Dental in Oregon. In Redmond, Oregon. And we're really passionate about trying to take care to the community. So I moved my career to where I was practicing part-time in a actual practice setting, but most of the time I was in public health settings and taking the knowledge and science to the people, and really looking at where were there a group of folks that weren't accessing care and how could we get them prevention and disease management services to really focus on caries prevalence. So my background and passion is really early childhood caries and focusing with pregnant women and young children. And so almost 9 years ago, we started working in WICs and Head Starts and school settings. And then about 5 years ago, 4 or 5 years ago, we kind of moved from just doing like risk assessments and fluoride varnish to doing more disease management, utilizing silver diamine fluoride sealants and fluoride varnish in combination with iodine, really trying to get that antimicrobial approach. And so currently in my role, I oversee a team of 15 expanded practice permit dental hygienists that are working collaboratively with a dentist, actually multiple dentists across the state of Oregon. And we're kind of connected virtually through electronics, through an electronic health record, to where we are providing, like I said, disease management services, which silver diamine fluoride is a huge piece and part of the care treatment, like the care pathway that we provide in community-based settings. So
you mentioned two kind of key things there, collaborative agreements or collaborative care with dentists, but also the expanded practice permits. Not every state is built the same. So if you could explain that a little bit.
So within Oregon, again, you have just your normal registered dental hygiene, but you can also apply to get an expanded practice permit endorsement, which allows you to practice in certain settings on certain populations across the state of Oregon. And then there's also another part on that to where you can have a collaborative agreement that allows you to do 4 additional services, which one has to do with like the risk-based part of that. Other is prescribing NSAIDs and antibiotics, and then doing anesthetics. those types of more in-depth services. And so within our organization and the role that I do, we're really focused on the risk-based care. And I forgot to mention, you can also do temporary restorations without excavation. And so we're really focused on reducing caries prevalence within the community setting. And that's really the area that we use that collaborative practice. There are many hygienists in Oregon that are using, the full scope of that, but ours is really the risk-based care and also the temporary restorations without excavation.
Do you need any additional training or education of any sort to have that permit?
Yeah, so they've, and it's years ago since I've got mine, so I don't even know all of the nuances of what it is now. But it used to be that you had to have like X amount of hours. I want to say it was like 2,500 hours and then 40 hours of continuing public health education for that. And then they changed the legislation. I believe it was in 2012 to where they changed what was required to have an expanded practice permit. And actually, there's some hygiene schools in Oregon now that when you graduate hygiene school, you actually already have that endorsement. So I feel like Oregon's really proactive within their hygiene education to deploy hygienists to work in the capacity as an expanded practice permit hygienist.
I've experienced that too. Like the board there is very, very willing to try new programs, they're so collaborative with all the different auxiliaries within the dental staff to get the care to the patients that need it the most. So Oregon is very much leading the way in a lot of this. Yeah,
and that's really exciting for, again, just those folks that really need to access care that aren't, and allowing all of us to work as a united dental team at the top of our license. So regardless if you're a dental assistant or expanded practice, we're working collaboratively with that dentist to be a team to ultimately improve the oral health of the population that we're trying to serve, which is pretty phenomenal.
And you mentioned that you are doing a lot of technology. Are you doing technically teledentistry?
That is a great question. We actually, I don't know that you would, what we've done in the past, you would, that some would really call it teledentistry, because we're not taking the intraoral images or radiographs. But what we're doing is that we actually have an electronic health record, like the population that we really serve is the Medicaid population. And so those patients that are assigned to like our Medicaid plan, we're connected to their dentist. So all the work that we do in the community, their dentist gets notified and to say, hey, Sharity may have saw John Smith at the Hermiston WIC office, and this was their risk status. This is the services that they've done. If you would like to, see more about what they did, please log in here and get more information. And so that was something that was really important to our organization, is because we wanted to, there are hygienists that are out there kind of practicing independently, and we really wanted to just be an extension of that dental office and really allow for, hygienists to work, collaboratively as part of that dental team to really provide those disease management services and care to those folks that may not have been accessing care, and then to help those dentists have that information about, their patient population that they may not have had the opportunity to see yet. And then they could kind of, reach out to them and say, hey, we saw that you were seen by one of our hygienists. We would really love to, do further in-depth services on you. Let's schedule you an appointment.
What software do you use to discuss all that?
So it is something that our organization had built internally. And so it's called ADEN, which stands for Advanced Dental Information Network. And it was something that, like I said, it was developed about 9 years ago within our organization. And that's when we really started doing community care. And I was pretty, vocal about, hey, we can't be practicing by ourselves. Like, we need to make sure that these doctors are aware too. So when that patient accesses care, that we're connected there. But to kind of add on back to Michelle, like what you were asking about teledentistry, we are in the process of building upon that platform that we've been doing for the last 9 years, and actually adding into those components to do more comprehensive and diagnostic services, to where we can, for those folks that are familiar with Dr. Paul Glassman and his virtual dental home, trying to have that verified healthy state, so we could continue to treat them in the community and they don't necessarily have to go in and see a dentist. And so we're just in the initial stages of trying to pilot and seeing how that can kind of build on to the existing infrastructure that we have done for the last 9 years.
And you mentioned Head Start and WIC, and, I personally have never really worked with children, so I know these terms, and I know a lot of our new grads and younger hygienists out there. Could we define that and what that actually means?
Yes, sorry about that. And again, and I appreciate the questions, because again, my career started in public health working in WIC, which stands for the Women, Infant, and Children, which is a federally funded program for folks that meet certain income requirements. It's a supplemental food program to where they can come in and get food vouchers, which was really interesting, because when, 16 years ago when I graduated from hygiene school, that was one thing that I had heard from as fellow colleagues about, when you go to the WIC office, they give so much juice, and juice is so horrible for the teeth. And so we were like combating, that, and, their food package has changed to where there's more, wholesome foods, and fresh fruits and vegetables. And so it was a really great area to kind of start, again, my career, because it takes in that nutrition component, which we all know is such an impact into the caries experience of a patient. And a lot of folks don't necessarily understand that connection between like the bacteria and the nutritional components, in addition to, their oral health and behavioral habits. So that's the key piece, I think, with WIC, is that, again, folks are coming in trying to get that nutritional supplement. And then within Head Start, again, it's a state and federally funded preschool program. There's early Head Start too, which encompasses pregnant women and children under the age of 3. But the most common Head Start is like that 3 to 5 age group before they go into kindergarten. And it's just to help them get ready to be within that school age population. And, they have a holistic approach too, with helping the family in addition to the child. And I think that's the two things that both of those organizations are really doing, is trying to have that holistic family approach to get, getting them ready for school, and just between the nutrition education and just how to help their family.
Can we just kind of then move into, I'm just curious about what this looks like on a day-to-day basis when you're treating patients, and what does a setting look like? Are you going into the schools? Are you going into these WIC offices? What does that look like?
So I'm just going to say that no day looks the same. It's kind of one of those things that, when you're in private practice, it's a pretty good chance that every 6 months you're going to see similar patients and kind of encounter the same thing. When you're out doing, community care, you're kind of more in control of your schedule, and you're really working and having those conversations with the community to try to identify where do they really need care. So the team of hygienists that I work with, one day they may be in one of the local schools doing, assessments and sealants. And then, 2 days later, they could be in a juvenile justice system doing assessments and other care. And then they could be in a WIC office like the following week. So it's really the environment that they're practicing in. They have to be very, very flexible, and it just kind of depends on the day where they are. But it's, all the sites that fall into within the scope where they can practice. Some of them were doing home visits. So they're going into residential facilities, for people that have, special healthcare needs that aren't accessing services outside of their home, and providing those, risk-based disease management and prevention services.
How do these, either the populations, how does the matching up happen? Do they sign up, or do the hygienists, are they responsible for finding populations to treat?
It kind of depends on the region. So within Oregon, and like I said, our focus is really on the Medicaid population. So within Oregon, with what's called a coordinated care organization, they have what are called community advisory councils and other community meetings. So we have, staff within our organization that are attending these meetings, or like the hygienists are at like the WIC and the Head Start or the school sites, and folks are kind of bringing it to our attention of, hey, this organization could really value and benefit from your service. Is this someplace that you'd be willing to work? And, we have staff that go and kind of talk to, which could be our expanded practice promote hygienists. They could be the local resource that are going and having those conversations just to try to learn more about the organization, and if it is one within the scope of practice of where we can provide services. And if so, what would that relationship look like? And then there's also, again, the hygienist kind of doing research about trying to find out what exists in their community and where may folks be going. And then so they could be reaching out to them. So it's kind of bidirectional, depending on the environment in which the hygienist and the community situation that they're practicing within.
And what does an assessment look like? Are you just following the understanding of Canberra, or do you have something very specific within your own software that you guys have created?
It used to be, again, when we started back in 2010, just doing just visual assessments. We really were trying to go along with the Association of State and Territorial Dental Directors Basic Screening Survey, which that is like a surveillance program that that most states use. So for an Oregon, like every 5 years, they do what's called a SMILE survey, where they go in and kind of determine the caries prevalence within like certain regions. And so we really wanted to make sure that our assessments aligned with that. So that's where we began, and worked with some of our competitors in the state of Oregon who were also doing community-based care to make sure that we were kind of capturing the same information. And we all agreed that was the best way to go. And so then we build on that. And in 2015, our organization actually implemented a quality improvement project to where we were trying to kind of evaluate the effectiveness of doing community-based care and utilizing expanded practice permit hygienists to reduce oral health disparities. And within that, what we did was, if you're familiar with the Canberra or the ADA's Caries Risk Assessment Tool or the AAPDs, they're all different. I mean, they have kind of the same, they're looking at the socio-demographic, they're looking at the clinical presentation of the teeth and, these other, risk factors and risk indicators. And within dentistry, it's kind of all over the place. And within our organization, we agreed that the one thing in dentistry that we can agree on is if you've had a cavity in the past, you're likely going to have a cavity in the future. So we began at that point to kind of switch our risk assessment on the clinical presentation of the teeth. So what we're looking at is there any like missing tooth structure? Because again, we can't diagnose as a hygienist, but we can tell if there are, if there's missing tooth structure. And so to kind of align with the ASTD's basic screening survey, and to also kind of look at, other systems such as ICDOS, where they kind of break it down into different categorizations of where you do different services or prevention services. We kind of looked at if there was there an existing sign of infection, and how we determined that is if you saw an abscess or you could see the pulp and, those types of things that we're not necessarily diagnosing, but we knew that there was signs of an infection. And if we did that, then that would make the indication that that patient was at high risk, and that our follow-up to care needed to be within 24 to 48 hours. The next step was, were there any visual changes in the tooth structure? And we really were focusing or defining that as, white and brown demineralization. Was there any opacities or any like gray shadowing? And those are the areas where we put them at moderate risk. So there wasn't like more than 1 millimeter of missing tooth structure. So you wouldn't kind of put it into that situation where there was a cavitation, but you knew that there was probably something going on. And so we would have indicated them to be moderate caries risk. if they hadn't had a cavity in the past 2 years, or there was no demineralization or any signs of infection, then those were the folks that we would put as low caries risk. And like I said, our services have really been focused on caries. And so based off of that, we had, caries pathways for the low, moderate, and high risk folks. And then how quickly they needed to get in to see a dentist for follow-up care. And then we would provide those disease management and prevention services within the community care setting where we were already providing them services and where we did that initial assessment.
And so this is at this point all visual.
Correct.
So no instruments in the mouth, no technology, no radiographs.
Disclosing tablets or...
Correct. So everything's based off of a visual assessment. They do have, disposable explorers, so they could, go in and put an explorer in the mouth. But typically it's just based off of, what they're seeing at that moment in time with their loops, or some hygienists wear the loops, some don't, and, what they're seeing and kind of basing it on that. And then again, within the scope of an expanded practice permit hygienist, we have to refer all patients back to a dentist that's willing to see them on an annual basis. And we have kind of a whole flow about, getting them back to the patient. And so everybody is just saying, hey, this does not count as a comprehensive exam based off of what we're seeing visually. This is kind of where we're ranking you at this moment, but you always need to at least see your dentist on an annual basis for, follow-up to care.
Has there been an issue, or do you run into this often where they can't get to a dentist, or there isn't a dentist willing to see them?
Within, again, our organization, like I said, we have predominantly focused on the Medicaid population. So within those folks that are Medicaid, they're assigned to us as a Medicaid member. Like, we know who their dentist is. We have a case management department that we're helping them to schedule their dental appointment, in addition to help them remove those barriers to care. If they are, with one of our fellow dental care organizations, then we're reaching out to that dental organization to say, hey, we saw one of your patients. This is what we're assessing them at. Can you assist us in getting them scheduled to the practice that's closest to them, or whoever you've assigned them to? And then it falls into, whether they have private insurance or they're uninsured. And with each of our communities, that's where these community relationships really work. We really rely on those community relationships, because we're having those conversations with them to say, okay, what resources exist for those folks that are uninsured? Or who are the private practice doctors that this patient may be able to see if they're not already an established, member? If not, then it's routing them back to who they're assigned, where their dental home is and where they've already been, seeking care. So it's just trying to, again, each patient is kind of handled on a case-by-case basis based off of, what their level of disease is and what resources are available in the communities, just to help make sure that they follow up and get that appropriate dental care.
If you guys are doing mostly visual, what are your tools for treatment or care of any kind, I guess?
Again, when we started 9 years ago, it was just like fluoride varnish. It was like we were slathering fluoride varnish like nobody's business. And then as, other tools came into play, which one was adding povidone iodine in conjunction with fluoride varnish. So we have that bacterial component. We began adding that. And then when silver diamine fluoride became FDA approved, we added that to our tools within our toolbox. And then we also, again, have done resin and then moved to glass ionomer sealants, in addition to also doing temporary restorations without excavation. So again, we can't remove tooth structure, but if we can tell that there's more than, a millimeter of missing tooth structure, or it's a little bit deeper than what we would do for the like a sealant, then we're looking at how we treat with silver diamine fluoride to have that arrest, and then add in the temporary restoration. So we're trying to stabilize them until they can get back to a dentist to have more comprehensive care with the radiographs and have that doctor do that diagnosis.
What materials are you using for temporary restorations?
We were using Kerr resin modified glass ionomer because the thing is that given that we're doing community care, equipment we have is pretty minimal, and we try. The team, again, they have little Ford Escapes. They load up their DeWalt toolbox and their mobile equipment, and they're driving around to different locations. And so we were, trying to find what tools we have within the oral health toolbox that had like the minimal amount of setup and breakdown. And the reason we went with the Kerr product was the fact that you didn't have to have the capsule mixer to mix the product. It was one of those things that you loaded and it self-mixed, and you could disperse onto the tooth. And then like late fall of 2018, GC America came out with a product, which I believe is called, I don't know if it's Fuji Auto Mix or Auto Direct. We got to test pilot it. And so I always get the two terms mixed up. But Fuji has a really great product now that allows us that has a higher fluoride releasing property that the hygienists are now using for temporary restorations out there. And again, you don't need the capsule mixers and that, but we did actually add, before we were using resin sealants in the community care setting. And a lot of that was due to the fact that within Oregon, if you were a certified sealant program, you weren't able to use glass ionomer sealants. And then they changed the legislation a year or two ago to where you could now do glass ionomer. And so we've been piloting the use of glass ionomer sealants and have the capsule mixers because of the Fuji triage sealants, and have been doing that since January of this year with great success. So again, we just continue to build upon the services that we're doing as new technologies come in regards to caries prevention and disease management, and add those to our community care toolbox.
With the Fuji triage and the glass ionomer sealants, do you mind just quickly going over if there's any difference in the steps that you would do as compared to a resin sealant?
So again, when you're doing the resin sealant, I think for all of those in hygiene, we're pretty familiar with the fact that it's really important that we need to keep the field really dry after you etch. So with that, you're etching, and then you're rinsing, and you're keeping, and then drying, and then placing the sealant on there, and then light curing it. With the Fuji product, it's not as technique sensitive, and you actually need to have the saliva in there. If you have it too dry, it doesn't work as well. And so when you're doing community-based care with limited equipment, there is a cavity conditioner that you can place on the tooth, and then you put the Fuji triage sealant on there. And the hygienist honestly use it like a wet Q-tip and just kind of rub it into the grooves. In addition, with part of our process with using silver fluoride, we really like the glass ionomer sealants because we can treat the tooth with the silver fluoride. So then you're getting the benefits of that into the enamel and dental tubules, and then placing that glass ionomer sealant over that.
Is Fuji triage light cure, or is it self cure or dual cure?
That is a really great question.
I think it's light cured because I just got some for Costa Rica.
And I guess my follow-up question with that is, with silver diamine fluoride and the staining properties, I would assume that there's some sort of informed consent or something like that needs to be signed or discussed or something.
With we started using silver fluoride back in 2015, right after it became FDA approved. And I will tell you, that was the one thing I always remember from hygiene schools. Our instructor said, don't be the first practice to, jump on board with new technology. And we jumped in with silver fluoride. I think that we did a lot of pushback because of the fact that it does. If you have any enamel breakdown or missing tooth structure or that's happening, it will turn the tooth dark. It doesn't turn, healthy teeth dark. And so it was really important to us that we made sure that the population that we were serving understood that. And so we have an informed consent that, that kind of walks them through the process. it looks like water. Now they kind of added a blue tint to it, so it looks like blue water. And when you paint it on the teeth, that it can help heal early tooth decay, that it goes on quickly and it doesn't hurt. And if there are cavities in the mouth, then the silver fluoride can stop them from growing and sometimes even heal them. And so that's kind of our message that we're going across. And we have included pictures because we are using silver fluoride as a way to prevent cavities, in addition to how to arrest cavities. So if you can see something that already looks like there's kind of some demineralization that looks as if something can be going on, then we're utilizing it in that to arrest the cavity that's taking place there. So, and again, we have pictures that show before for prevention and after prevention, which you can't really tell that anything's happening. But again, if you do have a lesion that could look suspicious, and we explain to patients and parents that the color change of that.
I think where you were going, Andrew, tell me, is that if you light cure, then you're going to turn underneath the silver diamond. It
precipitates it a little bit more. Right.
But my understanding in the courses that I've taken is that if you're putting a lighter, like an A1, A2 glass ionomer over top of it, because that's so bright and you got the darkness underneath it, it kind of grays it out and it's not so bad. I personally haven't applied this technique, so I'm just curious, but that's kind of the conversation I was having, because when I went into this course, I was like, but wait a second, I keep hearing don't light cure. So what's right?
Honestly, I think there's more research that's needed to know what's right. Again, when we started this back in 2015, folks would be like, yeah, go ahead and light cure the SDF. You'll see the color change quicker. And now, again, I was just recently listening to Dr. Doug Young, who, came on and said, light curing, no, that if the light itself causes any excess silver that hasn't bound to the tooth to oxidize. And so what that does is it's removing the active ingredient. It's kind of one of those things that if you're just doing silver fluoride on a tooth, that you wouldn't necessarily want to light cure it. And what we do within our program is if we know that we want to use the silver fluoride and then we're going to do a temporary restoration or do a glass ionomer, we will see those kids or that patient in the morning. And then like 4 hours later, we will do the sealant or the temporary restoration. One, it makes it more aesthetically pleasing. And two, it really allows for that silver fluoride to be absorbed into that tooth structure. Again, until there's more research that's done really looking at the evidence of that, that's just kind of what we're going with and taking all of the current research available and to try to do the best for the patient.
This kind of puts me into, I'm like, oh my God, because I'm not going to have that opportunity to bring them back. So I guess I am light curing and hoping for the best.
Let's be realistic about the populations, though, that she's treating versus what you'll be seeing on your mission trip.
Well, I'd say even in my outreach clinic, like it's all I can do to get them to stay in the chair because they have to go to their job, right? It was such a hard thing for them to take off of work to come even for that 1 hour. So realistically, could I, even an outreach program, bring somebody back later that day? So this is where I always get, because I'm not practicing with it often, I'm like, what do I do with all the information?
It's good, better, best, man. I mean, I think you just have to, decay is bad and we need to stop it. And so I think as long as they understand what it's going to look like, I want to actually know from Sharity, like, how do you actually apply it with like an interproximal lesion versus like your flat surface class 1, class 5 lesions?
When it comes to silver fluoride, I'm going to tell you it's dry, apply, and say bye. I think that's one thing that we've have been consistent about. If you look back at the previous, UCSF were the first to kind of go through like a step-by-step process, and it said to rinse. And so as we've gone and I think there's more research that's, taking place, we've moved to, again, the 3 simple steps: dry, apply, and say bye. when it comes to, I'm going to talk about if we're using as a preventative. So again, silver diamine fluoride, for me as a hygienist, it's just one of my tools in my toolbox, just as I would like a topical fluoride varnish. And so if I have patients that are at moderate risk, I'm not going to, slather it on like I would with a varnish. But, I can take that drop of silver diamine fluoride, and I can dry off the posterior occlusal surfaces and dip my microbrush in there and kind of massage it into the occlusal surfaces. And if there's something that's happening, you may see a color change, which as a hygienist, I love that because I have, like a visual indicator to say, oh, there's, some darkening that's happening down in this area. I can, talk to the patient to say, we probably need to talk about your diet a little more, or, if your brushing happens, to make sure that you're getting the bristle of the toothbrush down in there. And then you just kind of let them go and tell them not to eat or drink for a few hours, and not brush, and kind of send them on their way. Now, when you're treating like a lesion where, again, there is missing tooth structure, that if you're practicing within the dentist's office and the dentist said, this is a cavitated lesion, we want you to treat this to arrest it, or if it's an area where there's an incipient lesion that they want you're going to watch it, but we don't necessarily watch. We want to remineralize utilizing our, therapeutic tools in our toolbox. And so, placing that silver diamine fluoride, and again, you dry it off with your air, or if you're in a setting where you don't have your forced air, you can dry it off with your cotton rolls or gauze, and just, keep the area dry. You want to try to massage it into the tooth for, a minute. Again, if you're doing this on squirmy little kids, that minute may not happen. So you just want to try to get it in there as long as you can. Some folks will cover it with Vaseline, or they'll cover it with fluoride varnish. And the part of that process is really to prevent the saliva washout. There is no research that shows that that's needed. It's just kind of for you as a provider, is that something that will make you feel better. And for folks that I think as they're beginning to use silver fluoride, you will see them add the Vaseline over it or the fluoride varnish. And as you get comfortable with utilizing the silver fluoride and kind of see firsthand the impact that it has on the management and prevention of disease, then you may go away from that. But it's really kind of up to your clinical judgment on a case-by-case basis. And that's kind of, again, with the team of hygienists that I work with, that's, half will do it one way, half will do it another. And it's just their level of comfort as a provider.
Do you have any tips for sealants, like tips and tricks that you do, or even fluoride varnish? Because full disclosure, I've only worked perio. Now I'm in an outreach program. I applied varnish 10% of my 12 years in perio. So now when I slather and I'm like, ugh, do I let it dry? Am I letting them close? Do I need to dry things off? What are your tips for slathering it on these children?
And I always go back to the manufacturer's instructions and kind of look and see what they say, because as a hygienist, you kind of go back to be like, oh, what I learned in school. And then there's new products that come out. And as things change, you always want to go back to the manufacturer's instructions and kind of see what they say. But I am really, given that I'm used to working with little wiggly kids, those products that aren't like the unit dose, I'm a big proponent of the ones that come in like the syringe. Because what I would do is just squirt it on the top of my glove, and then I would have the kids sit in the chair. I would dry off the teeth with the 2x2 gauze, and I would finger paint. I don't use the brush. I'm just using my finger and kind of wiping it off and on. I try to get it as dry as I can be, but I know hygienists were registered to be picky and perfectionist. But when you're working in that situation, you really want to try to do the best that you can and just try to at least get that fluoride on some teeth within that child or patient or whoever you're serving. So again, you want to try to get it as dry as possible with that 2x2, finger paint it on the surfaces, have them close. And I usually say to my patients, like, this is the one time I will tell you, don't brush your teeth until the next morning. Like, I want that to sit on and let that varnish, absorb into the teeth. And the same thing goes when I'm using silver fluoride. It's just, you want to try to tell them to not eat or drink anything for at least an hour, and just try to stay away from food from 4 to 6 hours, and not to brush. But again, some of the manufacturer's instructions will tell you it's fine that they can, eat 30 minutes later. So, making sure, depending on the product you're using, that you're really looking at those manufacturer's instructions. So. And then, Andrew, I didn't address your question about trying to do silver fluoride for interproximal lesions. And I will tell you, I have firsthand of trying to do this on my son when he was younger and had some incipient lesions. And it's one of those things that for it to be effective, you have to have contact with the area. With younger kids, when they usually just have that, natural separation and spacing between teeth, it's ideal because you can get the microbrush, down interproximal. There are some other things depending on how compliant your kid is, or again, if you're using this on an adult, it's completely appropriate. Stimulants, those are like, you can, kind of put that in there to kind of get the space to try to get that down. And then I've evolved into using super floss. Again, super floss was one of my favorite tools in school and that I use when I'm practicing clinically. And so it's one of those for interproximal lesions. You can put that in interproximal and put the silver fluoride on there and kind of wick it down and floss interproximal. I'm always a little bit hesitant of using the same super floss for multiple surfaces, just because, again, if you do get silver fluoride on, skin, it will turn that dark too. And you don't necessarily, that's not very aesthetically pleasing for your patients to walk out with. So I'm always kind of conscious about that. I will usually use multiple super flosses just to avoid transmitting the silver fluoride onto, someone's cheek or their lip when I'm trying to get it interproximal.
And when you're using it, do you feed it through and feed it out, or do you do any of the snapping in and out?
It depends, but usually I snap in and out just because it's when you're pulling it out, if you have that, you're more likely to get it like on their, the corner of their lip as you're trying to pull it out. So I'm usually more snap in, snap out.
And I've given a few people the little black line on the side of their face.
I've done it.
Sorry, guys.
I've done it just a little bit because I work with Tepe Oral Healthcare, and so we have the floss that's short. The tufted floss that's short, and it's got the 2 ends for insertion. So for me, the snap in, snap out, I had a hard time like trying not to flick any excess out, which was why I did it once and I was like, oh, no. And then now I like feed it through until it's just at its end. And then I drop the silver diamine on it and then feed it in there and then just pull it through. And that has worked. I've only done it a handful of times, so take that with a grain of salt. But I was not branding people with silver diamine fluoride from that.
No, and I think that's perfect. And I'm sure that there's so many, different dental aids that are out there that I'm sure that there's, a lot of hygienists and those practicing out there that like, oh no, you should try this, that you could kind of dip it in. And I think that that's the biggest thing, especially when for me, again, we started using silver diamine fluoride years ago, and you have to be comfortable with it, because if you haven't done your research and you haven't, practiced and used it, you're a little bit more hesitant, because again, it can stain and it can turn things dark, and you're not sure what you're going to do. And if you actually get one of those tattoos on your patient. And so you have to be comfortable and you have to find something that really works for you. Again, the biggest thing is again, dry, apply, and stay by.
And it does go away, people. Like it's not like an amalgam tattoo where it's there for a while. It does start to fade away.
it's just that epithelial layer when that goes. And I will tell you, I had a colleague whose niece had it applied and she sent me a picture and it was all over. They actually went to the pool. It was in the summer. So they went to the pool and it was lightened up by like a couple hours after she went to the pool. So again, for your little kids, just take them swimming. No.
Yeah.
Have you started to see, and it's really early on, but have you started to see and document any successes with the procedures that you're doing?
Yes. Now, and that's one of those things that we have like 4 years of data and we have not really looked at that. And so we have a team now that is really starting to look at it. Because again, since how we did our risk assessments, we were really trying to focus on like that calibration of the EPDHs that were out there doing community care, since we were focused on the clinical presentation. And so we have the ability now to look at our risk assessments and see if we're, improving the health through these therapies that we're doing in the community. And so I'm hopeful that here in the next few months, we'll have some data to show, anecdotal data from those like Head Starts that we've worked with. They have their annual reporting that they have to do. And it used to be that their levels of dental urgencies were much higher. And we're seeing those drastically drop based off of what the Head Start sites are saying. The hygienists that are working in these communities, they're getting excited over the past few years because they've seen a huge difference. So again, what you see personally, but I really want to go back to the data and make sure that we have, concrete evidence to support that what we're doing. But again, what folks are saying and what the initial interpretation of the data we're looking at is, we're really seeing positive results in the risk assessments, and the number of dental urgencies are drastically dropping since we implemented this back in 2015.
If you can remember, we would love probably a little audio clip of the results when they come out, if you're allowed to share them, and then we'll put them on a future episode. I'm sure everyone will be really interested in hearing that.
Yeah, no, definitely. Again, we have a new COO who's like all about the data. And we have another team member that is like really looking at that. So again, I honestly have data from like 9 years. So I'm hoping that someone will be able to kind of look as we've moved through all of these, and we'll be able to report on it. And I'm happy to share.
Awesome. Before we wrap up, I'm just curious about what you guys are doing to prevent decay. What are some of the conversations or tools or tips, tricks with this patient population that you're recommending?
It ultimately starts with the patient. And that's one thing that I'm going to say that our team is really great about, is trying to get to know the patient and where they live and the environment in which that they live in. It's really easy for us to say that they need to, brush twice a day with fluoride toothpaste and have their own toothbrush and to eat a balanced diet. But I have learned, and what our team has learned, is that their access to having their own toothbrush and toothpaste to be able to do those behaviors we recommend isn't as easy as we think. And their access to healthy, nutritious foods aren't as easy for them to access. And so that's one thing that I think we really try to look at, is the environment that these children and their families live in, and help them remove those barriers and look at those situations to where, if it's one of those things, if they're having a diet full of, high sugary carbohydrates, and their eating frequency isn't ideal for caries prevention, trying to have that conversation with them about what is one small self-management goal that you could set for yourself within your reach to help you improve your caries. So I think that that's the first thing that we do, is try to establish a relationship and understand where they're coming from, so we can give them tailored information and help them set self-management goals. Because again, what we do in the community or in our office is like 10%, 90% is the behaviors and what they're doing within their everyday life. So we really want to, reinforce that. To build upon that, we've really found that trying to have that antimicrobial component to caries. I think that's one thing we can agree, that there's a bacterial component in addition to, feeding the bacteria the sugary foods. So we really look at that fluoride varnish in conjunction with the povidone iodine, which that's something that I had never heard of until about 5 years ago. Like I said, I was, putting fluoride varnish on, kids' teeth. And if I saw the white spot lesion, or adults with white spot lesions, just putting fluoride varnish. And the use of povidone iodine will actually, you just put like a drop in a Dapin dish, dip your Q-tip in it, wipe it on the teeth, wipe it off, and put your fluoride varnish on it. And it actually research shows that it reduces the bacteria level between 90 to 120 days. So if we have these high caries risk folks that are coming in, it allows us, the provider, to try to get ahead of that with the bacteria reduction, and increases the efficacy of the fluoride varnish by 36%. I really loved when I learned that tool. And then when, silver diamine fluoride came in, that was the other antimicrobial, because I feel like there's a lot of stuff that we do in dentistry, but we don't ever really get to like the root cause of what happens with that. And so when I, learned about silver fluoride, I was having a conversation with a medical colleague, and I said, if a child has an ear infection, they come in and they get the round of, antibiotics. And if they get in again, they come back and we give them another round of antibiotics. And then if it keeps happening, then eventually we'll go to tubes. I'm like, if you compared that to dentistry, the first time that they come in, they would remove a part of the ear and put a plastic material in there. And so that analogy is something that I've really, you can share that with a family member and a parent. Like we've all, if you have kids, you've had to deal with earaches and ear infections. And so this is something that really resonated with them. And it was kind of like eye-opening to me and my role as a hygienist about one small thing that I could do to try to improve their caries experience. And again, since my passion is really with, pregnant women and young children, and given the level of, caries prevalence in that population, those are two tools that as a hygienist that are in my toolbox that can really make an impact. And patients can understand because I can relate it to, something medically that they've experienced, again, with their children or somewhere in their family, of how they can be in control to improve the oral health of themselves and their children and family.
Love it. What a great way to wrap this up. That was so many great suggestions. Thank you. And you thought you couldn't talk for an hour. See, I told you, if we could get some money every time a person told us that, this podcast would be fully funded. Well, we really do appreciate you coming on. And I would like to just wrap it up. If you have any suggestions for maybe our students who are going to graduate or even just getting started, and they're just so smart, they're listening to a dental hygiene podcast, what suggestions would you have for them to either start looking at public health or be confident enough to graduate and go into public health?
Again, my career started as my senior capstone project actually was to go into the WIC office and do nutrition education to pregnant women and children. Just so you know, I became a hygienist because I wanted to work 2 days a week and be a mom and make good money. I've been a public health hygienist since I graduated 16 years ago. And I would have never thought that my senior capstone project would have introduced me. Again, my mentors of this, my senior capstone project, again, like I said, was in the Klamath County Public Health Department. They actually received a Robert Wood Johnson Foundation grant to implement an early childhood cavity prevention program, of which I attended their subcommittee meeting for, and got to know Dr. Peter Milgram and Dr. Mike Shortcliffe, who was the president and founder of Advantage Dental, who I work for. That is kind of how my progression of my career has gone. I would never have thought myself as a public health hygienist if it wasn't for my senior capstone project. Just be open. there's some things that you go through school and in your career, and you're just kind of questioning the people that you meet along the way. Just be open to that and to listen to them, to see where that takes you. Because again, I feel like my career has been pretty serendipitous, that I've been at the right place at the right time. But I've had the will and desire that I wanted to be a part of something awesome, and I wanted to make a difference in the lives of those I've served. And so when you have your why and your passion as a hygienist, and anything you do in life, like, it will keep you on your path and help you go far. So just persevere, because there's great things ahead.
Yes, so good. So if anybody has any questions or wants to reach out and contact you, how can they do that?
My email is charityl@advantagedental.com. Do you want me to spell it out? Sorry.
We'll put it in our show notes. It's okay. Yep. We'll put it in our show notes so people can find you. But this was so great. This was wonderful. Thank you so much for coming on.
Yeah, thank you, Sharity. Wow. Thanks, Sharity, so much for all of the hard work that you and your team are putting out there for the people of Oregon. I think that there's a lot that we can learn, I think, from her. A couple of things, though. She also mentioned in an email, I want to do some more clarifications. So one of the EPDHs asked the question, why is it that pink GI material will light cure and the white material does not? And the GC rep replied to them and said, neither the Fuji Triage shades, white or pink, have photo initiators in them, so they are technically not a light cure material. However, glass ionomer do set up when exposed to heat. So it's actually the heat from the curing light that helps it to set up faster, and the pink pigments have been shown to set up quicker to the heat. That's kind of an interesting thing. And then she also wanted to share one of the tricks that she has when using SDF to help combat the taste.
Yeah, this was a good suggestion.
Yeah, it really was. She said that she, to help combat the taste, they put a little bit of children's toothpaste on a gauze or smear a tiny bit on the tongue. So when they close down, they just taste the toothpaste and not kind of like that metallic taste from the SDF. She's like, man, give it a try. If it works for you, then it's a nice little tip.
Yeah, that is a good tip. And I wish I had read that before I went on my mission trip, because those poor little kiddos were closed. Well, luckily I had that wonderful suction from Dental Works. So that was nice. So I could suction as much as possible. But I also want to give a quick little shout out to Lisa Hardill, who was very helpful for my trip in using SDF, gave me a little instruction sheet and everything. So I appreciate you for doing that. And everyone who's given me any suggestions on how their little tips and tricks for using SDF, like in the settings with kids and all of their saliva.
And your episode that's going to be talking mostly about your Costa Rica trip, I think, is going to be on the 26th of next month.
Yeah, so keep an eye out for that.
Okay, I think that's it for this episode.
Yep, because Mama's going back to the couch.
Okay. So, find us in Instagram.
Don't make me laugh.
Instagramming and Facebooking and the things. A Tale of Two Hygienists is our name. So just Googling us. Okay. Well, see, and this is why I can't leave you. So check us out on Facebook and Instagram. You can also email us at ataleoftwohygienists@gmail.com. And you can head over to our website, ataleoftwohygienists.com. We love your direct messages. We love your emails. Don't forget to leave us a review on iTunes or rate us. If you only got time to rate us, we'll take it. Keep downloading, keep spreading the word. We really do appreciate you guys, and keep learning. You guys are amazing. And thank you to PDT for all of the continued support. And check out the show notes for the CE code so you can go take the test and go get some CE credit for this episode. Yeah, and PDT actually has a lot of new instruments out. If you guys are working with any of these all-on-4 cases, they have a very cool Pinheiro kit that is a set of scalers to get up under those lovely fixed prosthetics. So check those out. And if you're at ADHA or RDH under one roof, let us know, because we would love to meet you at the PDT booth. Mm-hmm. All right. Have a great week, everyone. Bye, everyone.